Yeah.
Good evening, one and all present here. I am Mona Lisa from Journey. The digital session is meeting for the serious community. Journey is India's most trusted and widely used digital platform, exclusively used for doctors. Journey is very proud to be a part of the digital part which organized by Indian starting of and the topic of today's session is interactive session OSCE spotters and Viva questions. Thank you for your patient hearing, everyone. So let's begin today's session, for which I would like to invite Dr. Nihal ma'am to take it. Over to you, ma'am.
Thank you so much, Clarinet, for providing this platform for all the pages. And I welcome you all for E-Gurukul Pathshala PG Clinic, our Saturday evening program, which is very popular among PGs. Today we have interactive session, that is OSCE sessions for spotters and Viva questions. And for this, we have our own and beloved teacher of teachers, Baldev Prajapati sir, who is also a convener of this program. And sir is a professor and head at GCS Medical College. I need not to introduce him as everybody knows him and he is very popular among PGs. For this, we have participants, though we have selected 5 participants to take mainly discussion in this session, but any students who join can definitely take part in the discussion. So we have Dr. Shivangi Kimoti, who is second year resident from a BJMC Medical College, Ahmedabad. Dr. Chandraprakash Soni, he is a third year student from GMERS Gandhinagar. Dr. Chinmay Desai, he is SR at GMC Surat. Dr. Aarti Solanki, who is JR3, third year resident in GMERS Sola. And Dr. Drija Patel, she is SR at GCS Medical College, Ahmedabad. So I welcome all students and have a great discussion. Thank you so much, Yogesh sir, for being a project in charge and your thought of this wonderful program. I also welcome my colleagues, Dr. Aarti Kinikar and Dr. Vaishali Joshi, who are project coordinator for this program with me. Baldev sir, the platform is all yours today.
Good evening, friends.
Good evening.
Good evening, sir.
Yeah, say good evening. So I understand that you have very nice zeal and enthusiasm.
Good evening, sir.
Good evening, sir.
Good evening.
Good evening, sir.
Yes.
Good evening.
Let me express a word of gratitude to Dr. Nehal for organizing this interactive session. And of course, our president, main person, I will say, behind this whole project, Dr. Yogeshwar, and the whole team, Madam Dr. Aarti and Vaishali from Goa. And you know that so many people are working so that we get the prepared platform for the discussion. And I think we should not forget them. Actually, I wanted with this introduction of the students, but already Madam introduced. And I came to know that Dr. Shivangi is from BJMC. Dr. Drija, actually her designation is given from GCS Medical College, but she is from Pune. Dr. Aarti is from Sola, am I right? Dr. Chandra
Yes, sir.
from Gandhinagar. And Chinmay, that's good that every time he's there. He's from Surat. Nice to see all of you. And one more, Dr. Dhaval has joined. Let me give you the idea that today's session, we organize some concepts in our mind. All of you know that for the DNB students, that is one OSCE pattern. Similarly, you know that if you are knowing the pattern of exams will be different, but if you are knowing, probably all of us can respond properly. Similarly, in the MD examination, the spotters are there, 3 spotters are there. And you know that it's just to start this dialogue or the interactions. There are various ways. Sometimes your various questions are discussed in the Vivas. So keeping in mind all these points, now discuss these type of sessions at different platforms with the several postgraduates at different medical colleges. And I came to know that it works very well and quite useful to the students. This is just to give the idea to sensitize you with some illustrations that what type the case is, what type the OSCE is, what type the things are there, how most of the examiners are framing the questions. So probably you will give the idea. I know that you have the idea, but still probably it will be more clear that how to interact, how to answer, keeping in mind some of the OSCEs and spotters, some questions common for the Vivas are selected. I thought that we will not go in a form of the dialogue that just I will project this slide and I will continue to speak and you'll be the just passive listeners. I think you know gradually I'm learning as a teacher also that of the sessions are not much useful. Always it should be interactive. Whatever the students are knowing, whatever they have the concepts, whatever they are in their mind, let them express. And even as a teacher, I will try to understand that why he or she answered in this way, what she did the mistake, and how we can rectify the mistake so that at least it does not happen in the exam. Similarly, I think same things are useful in our daily practice also later on, not just only for the exam point of view. You know, exam is one milestone for all of us. Therefore, we are preparing, but ultimately our goal, you know that by learning the medicine subject, you can have the good, at least successful performance in the practice, wherever you are working, either in the institution or even in the private practice. I think having this understanding will start the session. And what I wish that I will project this slide, and with that slide I will put some of the questions. I wish that all of you spontaneously you can interact with me. Either you can raise the finger because you are multiple students, or even spontaneous you can speak. And one by one question something will take and will go ahead. But I wish that all of you should interact. Whatever comes to your mind, don't hesitate. Same thing happens in the exam. But we will try to rectify and correct the answer that what it should be. I think with this, let me start. I will share with you these slides. Every time you are sharing these slides with me, today I am sharing my slides with you. Are you able to see my slides?
Yes, sir.
Yes, sir.
Is it visible?
Yes, sir. Yes, sir.
Okay, and I hope that I am audible also.
Yes, sir.
Okay, you know, many times nowadays, even suppose patient is not available, many times examiners are bringing these are the pictures. They may project on the screen or laptop and they will conduct the exam. There are various methods now. We are evolving at various places. So this time a child is there and this development is following the BCG vaccination in the infant. And with that, after this picture, let me put some of the questions. Is it normal or abnormal following the BCG vaccination?
Abnormal. This is abnormal.
Okay,
Abnormal, sir.
okay, one by one. Dr. Chandresh, what
Yes,
is
sir.
first say me the what is normal reaction following the BCG?
After BCG, even first within 20 to 30 minutes, there is a formation of wheel, and within 2 to 3 weeks, there is a formation of vacuole, and within 4 to 5 weeks, there is a formation of nodule. After that, there is a lump, and then followed by ulceration, and followed by scar formation within 8 to 12 weeks.
Very good. So here what is the abnormality?
Sir,
Abnormality
if
here is
someone is
BCG
calling,
adenotized.
just a minute, just a minute,
Yes,
just a minute.
yes, Nelvin.
Sir, if someone is calling you for the link, tell me the name. I will give him.
Okay. I think I will request even those who are on the attendees link that if you wish to join, you can just send a message to Clarinet person or Nelvin or to me. Sure.
Yeah,
Very
I will,
good.
sir. Okay.
Thank you. Yes, absolutely. Now let me go further. Yes, what is the normal BCG reaction? Very rightly Dr. Chandresh described, and this is very common. People may ask you that there is the wheel formation of 5 millimeter at the injection site following the successful intradermal. Intradermal injection, they say the P2 orange. What is it? Dr. Shivangi?
Sir, that is due to infiltration of the lymphatics. So due to that, the pudgy orange appearance appear. There,
First, what do you mean by the P2 orange?
there is small depressions in the said area, the involved area.
How the name is derived? Any idea?
Due to the cover of the orange, like that, there is a small like heart area and small pits are there on
Okay,
the.
here the pits are due to what in the intradermal injection?
Uh,
Any idea? Anybody else?
So this is called the orange peel appearance, food
Yeah.
orange. And the pits are actually to do the hair follicles, the hair shaft.
Absolutely, absolutely good. So what happens? It is just like the skin over the orange bark, and you must have seen that there are multiple pits over the orange scene. Similar appearance, but here the following the interdermal, why this appearance is there, and your lymphatics will take time, Dr. Shivangi. But here, due to the veil formation, there is the elevation. But in the air follicle, there is the depression or pits are seen, multiple pits. So appearance with the swelling and the pits, as if this orange skin is seen. Therefore, they say and that is the criteria for the successful intradermal injection. And this will subside within 30 minutes around. Later on, no visible change for several days. Very rightly, Dr. Chandresh was describing later on the papule formation in 2 to 3 weeks time. And then 4 to 8 millimeter size, there is the pustule formation. And pustule, sometimes what happens that it burst opens and gets sealed off. Maybe even once, sometimes multiple times. Parents will ask us. And later on ulceration, scab formation, and it subsides by the superficial tiny scar. So I think we should know that what is exactly this BCG, and not necessary in all the patient, this sequence will be there. Sometimes just papule formation and direct scar will be formed. So that is also normal reaction. It should not confuse us. And the parents will ask the multiple questions because they will be afraid that what happened, this ulceration, discharge continues for weeks together. Very good. I think with that next question, if I go, I don't know, I'm not getting completely, but what is this abnormal, this vaccination following that?
This is it.
Yeah, here it is the ipsilateral anterior cervical lymph node, and that is less than 1 centimeter size. It may develop following few weeks or months after the vaccination, and node subsides spontaneously. No antitumor therapy, nothing is required. But here, like which I showed the picture, what should be line of treatment? Dr. Chandra?
Yes, sir. We can go for IND, and if need of antibiotics, we can go for antibiotics. Otherwise, no need of AD. Or we can go for powder form of INH also.
Okay. So, Dr. Shivangi, what is your response?
Sir,
And I'm sure these are the answers in the exam, and I'm sure that you will face the problem. Dr. Shivangi, what is your idea?
as the lymph node is more than 1 centimeter, we can go for antibiotics, and we can go for local part USG to guide if we need surgical drainage or not.
Okay.
And after course of antibiotic, we can reevaluate the size of lymph nodes if it has gone down or not.
Dr. Chinmay?
So this is the condition is called the BCG-OSCE disease, and it requires if there are like 3 to 4 criteria which if they are fulfilled, then there is a need to start the anti-cox therapy. If the patient presents within the first year of life, in the infancy, or unilateral lymph node of more than 1 centimeter size, and without any systemic systemic symptoms such as fever, chills, or weight loss, it is very likely that it could be this BCG versus disease. And after that, again, AKT is warranted in these patients.
I think when I was selecting this question, I felt that everybody knows why I should go. But now I know that I selected the exact question. And very common in the paper. I think I'm not able to see others on my screen, but I think Dr. Aarti was also there.
Yes, sir.
Dr. Aarti, what is your idea?
Sir, if lymph node is in increasing size or it is increasing gradually, we will do incision and drainage. There is no as such role of antibiotic in this thing.
Okay. Very good. I think please keep in mind, and I request all of you, you must be aware, recent our IAP, that is a advisory committee on vaccination and immunization. They have published one purple book just a few months back. And please go through it before your examination. About 500 pages, but if you decide probably in 15 days, you can complete it. And you know the vaccinology is a super specialization for the pediatrician. And therefore, all of us should know what should be done. Let me project to save the time. If the lymph node size is more than 1 centimeter, less than 1 centimeter, I say don't do anything, it will subside by its own. And if there is suppuration, that is abscess formation, first go for the only needle aspiration. And it may require even repeated aspirations. But really larger size that require the repeated aspirations, or somebody may repeat the repeated aspiration, go for surgical excision. There is no need of anti-tuberculosis therapy, no need of antibiotics. I think what Dr. Chinmay you said, BCGosis is quite different. This is BCG adenitis. BCGosis is particularly the dissemination of this infection following BCG vaccination. And that is more common, particularly with the immunocompromised status of the child. If you don't know and somebody if you give the BCG, it may happen so. That may be in a case of Mendelian susceptibility mycobacterium tuberculosis, that is one of the immunocompromised status, or even severe combined immunodeficiency. That will be the dissemination of this BCG vaccination. And there may be the lung involvement, one liver, spleen. That is a quite different situation, right? It will require the different management. Here, it is just BCG adenitis. And you know that any role of antibiotic, and we already discussed, BCG adenitis is more common with the subcutaneous BCG administration. And there is no need of ATT, no need of the antibiotic. Even if you go for surgical excision, that's all. No need of the anti-tubercular therapy. So I think this is very common even situation, maybe in our practice, and we should be aware of it. I think Srinivasan sir is also there. Sir, if you wish to anything, please just you may indicate me, please.
Yeah, everything is fine.
Thank you,
Told
sir.
everything
Thank you, sir.
correct.
Thank you, sir. That is another thing. Let us go further. There are so many things. What is the commonest genetic cause of the intellectual disability? Arti? In our pediatric practice, suppose somebody asks you that the condition is genetic condition. And most common in our practice for the intellectual disability. Now, you know, if I remind you, don't say mental retardation. Most of the people don't like. And particularly in our exam, they may turn the face. Here, use the terminology intellectual disability. What is the most common cause? Dr. Chinmay, Chandresh, anybody? I think nothing abnormal or unusual or uncommon, I'm asking. It's very common condition in our practice.
So Down syndrome is
Yeah, it's a
because of
chromosomal.
chromosomal
Absolutely.
size.
It's a Down syndrome, and they say that at least 20 to 30% cases of intellectual disability. If you say 100 patients of intellectual disability, out of them almost 20 to 30, they are Down syndrome. And what are the various types of karyotyping in Down syndrome? Dr. Shivangi?
The most common is trisomy of 21 chromosome.
Haji? Yes, Aska.
There could also be mosaicism
Right.
and
Robertsonian translocation.
Okay, very good.
Maternal risk.
Okay, why I've selected these questions, the Down syndrome is very common as a short case in the MD examination, or even similarly the spot cases, or even in these OSCE cases in the OSCE questions in a case of the DNB exam. Various types of the karyotyping we should know. All of you know that it is a trisomy 21. How it happens? More than 90% are the non-disjunction. What is the non-disjunction? There is an extra chromosome from mother due to failure of the separation of the chromosome during the meiosis. Stage of meiosis, all of you know. And it is more common with the advanced maternal age. Therefore, in the history, always we ask the age of the mother in a case of the Down syndrome. And that is the non-disjunction, which is the most common. Second one is the 4% you may get the translocation. What we mean by the translocation? Here is the translocation of chromosome 21, any of the D group chromosomes 13, 14, 15, or G group chromosomes 21 and 22. That means material of 21 chromosome is detached and attached to any of these chromosomes. And what even Dr. Shivangi was telling us, 1% mosaics. What we mean by the mosaic? One cell line with 47 chromosomes and normal cell line with 46 chromosomes. And therefore, these babies, mosaicism, many a times there may be very mild manifestations of Down. Or even sometimes you may consider this normal child, but having some issues. So in short, therefore they are very mild. And mosaicism, the different shapes, different types of the tiles. Here the different type of the chromosomes. So I think that's a various type of karyotyping, which all of us should know. My next question, in which type of the Down syndrome karyotyping of parents is necessary? Suppose if you ask for the Down syndrome, in the case of Down syndrome karyotyping, your genetic person will call you that I want to go for the karyotyping of the parents. Why? What is the need? Anybody?
In music.
Robertsonian translocation.
Okay. Dr. Aarti?
So translocation.
Okay, why the translocation? Any idea? Let me answer, you are right. Dr. Chandra is not in mosaicism, but translocation. But why the translocation, Dr. Aarti? What is
So because one of the parent must have that abnormality in their gene, or they must,
absolutely? Yes, that's
because
and
in that case age is not the factor.
absolutely. They are carrier. And the future child can also be having the problem. Therefore, Down syndrome caused with the translocation, one of the parents may be the carrier of a balanced translocation, what Dr. Aarti was telling, absolutely right. And therefore, risk of Down syndrome in the offspring of a translocation carrier, mother is 10 to 15%. And suppose father is carrier, chances of 1 to 5%. So I think that when the genetic specialist comes to know an analysis that this is a translocation variety of this Down syndrome, then they will request us that we should go for the karyotyping of the parents. And suppose parents are carrier, we should go for the genetic counseling. That these are the chances of development of the Down syndrome in the future to their offspring. So I think that's the point that why we should go. And what is the risk of trisomy 20 of the offspring of women with trisomy 21? Risk of trisomy 21 the offspring of a woman, I think due to the picture, it gets a little bit, yes, women with the trisomy. Anybody?
Sir, I would like to try.
Yes, yes.
Yes. So if the
Did you get my question? That suppose mother herself is trisomy 21 Down syndrome, and then
sir,
passes to her offspring.
no, sir. Sir, it is that if the mother is having trisomy 21, there is not 100% chance in the offspring getting the same chromosome, because during the meiosis in the mother, during gametogenesis, the chromosome would again be split, and this is, sir, what I remember.
Okay,
Chances are,
anybody
sir,
else? So Chinmay said that there is no chance. Am I right, Chinmay? It is your response?
not 100% chance of
Then
inheritance.
what person? If not 100%, then what person? Okay, anybody? Anyway, to save the time, I will go 30% chances. If the mother is suffering, mother herself is a case of Down syndrome, you can explain that there are 30% chances to her offspring to develop the Down. At the same time, next question people are going to ask you, what is the risk of trisomy 20 the offspring when in the of man with this trisomy? Father, himself is case of the Down. Then what are the chances of trisomy in his offspring? Shivangi, Arti, anybody?
The same 30%.
Okay. I'm
1 to 5%.
Yes, Arti.
Chromosomal disorder.
Arti said something.
So 1 to 5%. I'm not
Okay,
sure.
1 to 5%. Are you sure or just it is your guess?
Sir, I remember that table, but I'm not sure about the values. I'm not
Okay.
clearly remembering it.
Okay,
But,
okay. Here, you know, that means if you know the principle, you will not do the mistake. The question is asked purposefully. That means you are aware of this principle or not. And the answer is males with the trisomy 21 are usually infertile. They don't have the offsprings. So please remember that female with the Down syndrome can conceive, but male with this Down syndrome, they are usually infertile. And therefore, there is no question of what percentage they will have. Right. So I think this is the thing. That means you should remember that female can conceive, but male is going to be the infertile. That's the answer which we should remember. Okay. What are the problems or diseases associated with the Down? Chandresh, I think this is an easy question.
Yes, sir. Congenital heart disease, sacral agenesis.
Right? I think, you know, congenital heart disease, undergraduate says I will be happy, but not from the postgraduate.
Yes, sir. ASD is the most common.
ASD, okay, but still what variety of ASD? Another
Uh,
answer in such a way, don't give the opportunity to the examiner for the next question.
okay.
Okay, very good. You can just try. Anybody else? What variety of ASD?
It is endocardial cushion defect.
Absolutely. Absolutely. Endocardial cushion defect. Anything else? Very good. Further.
Hypothyroidism.
Hypothyroidism.
leukemia.
Shivangi? Absolutely.
Leukemia.
Absolutely. Absolutely. Good.
Duodenal atresia.
Yes.
Leukemia.
Okay, let me put here. Hypothyroidism, we're absolutely right. Even deafness is there, leukemia is there, atlantoaxial instability. You know, that is very common. Sometimes, if you don't know, suddenly the child will present with the paresis. Even epilepsy is common in the children.
Duodenal atresia.
Duodenal atresia, yes, malformations, absolutely. Risk of giving the birth to a child with Down syndrome with the increased maternal age. I think this is very common question which we should know. Just I will answer, you can remember. That at the age of 20, it is less chances, 1 to almost 2000, which comes to 1 into 1200 at the age of 25. And gradually it is, you know that as the maternal age advances, there are more chances. And after 35 increases tremendously. And 40, 45, you can see. So just to, you can remember that what is the relationship with the advanced maternal age and chances of Down syndrome. Okay. Why the chromosome analysis of every child Down syndrome is necessary, even if the diagnosis is clinically obvious? You know, it's a clinical diagnosis. Why we should go for analysis? Yes, anybody? Shivangi, Aarti, Chandresh?
Sir, for risk of sibling, if baby is, as we already discussed, baby is a translocation type, we can assume that next baby or parents also have risk of that.
Right. So depending upon the type of chromosomal abnormality, carrier status, where absolutely Dr. Aarti responded, and therefore this is the idea that every patient we should go for the analysis. I think that's the point which we want to convey in the practice also. What points to be checked or assessed during follow-up in the case of Down? Again, this is a very common question. Suppose if you have got the short case, they will ask you that how will you do the follow-up of this patient? Shivangi?
Sir, we do TFT
Right.
and then X-ray neck, and then workup for celiac also in Downs we do.
Sir, ophthalmologic examination every yearly,
Yeah.
then echocardiography every 3 yearly. After 10 years of age.
Is it so? Suppose once you have done the echo, there is no congenital heart disease. Still, you are expecting that the later on it will be detected. Cataract can develop, it is possible that initially it was not there, but after some time it can be there. But suppose echo once you have done, it's supposed to turns out to be normal, then I'm sure that structural abnormality is ruled out. Am I right? Okay. What are other tests which you should do, or very specific you should be careful for the follow-up?
Blood investigation to diagnose leukemia in early stage.
Okay, good. At what time, any idea? At what interval?
After 10 years, sir.
They are given the guidelines. Anyway, please remember, eye examination, very rightly we say, specific report cataract. Hearing assessment, that is also very important. And yearly evaluation of thyroid function test yearly. That we should be careful. Almost they say 15 to 20% of the Down syndrome may have the associated hypothyroidism. And evenly atlantoaxial the instability. So Shivangi said very rightly to assess the X-ray or some video imaging better. And PS examination for leukemia, that is also yearly. That is to be done. So I think in follow-up, in short, you should keep in mind that the children are vulnerable, and therefore we should keep in mind. I think what Shivangi said, it is also not totally wrong. Even celiac or diabetes mellitus, these autoimmune disorders, is more chances in these children. So that also you should keep in mind. Okay. What are the components of, I will say, triple test? Which disease, and which disease the screen? Sorry, just I press it and the answer is there. Please remember what is the triple test. Usually it's a maternal serum alpha fetoprotein. Maternal serum alpha protein is going to be low in the all trisomy chromosomal abnormalities. That is 21 trisomy, 18 trisomy, 13 trisomy. That is Edward and Petrov syndrome. That alpha fetoprotein is going to be low. Unconjugated estradiol will be high, and free beta SCG will be high. This is called as the triple test. And that somebody may ask you that what are the components and what is the interpretation of it. Next question, name the 3 radiological findings that suggest the presence of the disease. I'm asking intra-uterine. When you are following the during the pregnancy, with the radio imaging, mostly commonly sonography we do, what are the points which will suggest you that there are chances of Down syndrome?
Double.
It is knuckle translucency, double.
Absolutely.
Knuckle translucency more than 3.
Yes, yes, Chandresh. Dicha?
And aplasia of nasal bone.
Even you know why these questions any examiner is going to ask you, because this is the common things which we face in the practice. They will come to you with a sonography, that obstetrician said something, radiology, and then at least we should know that what are the important points to be noted.
Sir, aplasia of nasal bone.
Okay, that is also as nasal bone important, absolutely. Anyway,
And,
save the time I go for the answer. During second trimester, then even timing is also very important. During second trimester, increase nuchal fold thickness. I think that we should know radiologically what is normal. Then
Less than 3 mm.
short femur and the humerus. Short long bones, that is also important. During atresia, when there may be the evidence. And in the first trimester, what Chinmay was telling us, nuchal fold thickness and nasal bone evaluation. They are very important markers in the first trimester. So I think by sonography, whenever suppose some mother is down or some situation, we should know these points that how they interpret, or we should keep in mind. Okay, how can a definite diagnosis can be offered at this stage? Suppose some
Carrier
ambiguity, yes, and that is
Chorionic villus sampling.
Choriovenous first trimester.
fetal karyotype amniocentesis. And why this series of the questions I have put it? This is very common situation in our practice. And I think it is expected that every pediatrician should be aware of it. So that, and this, therefore, in the exam also they will ask the questions with some purpose, not just whether you know or whether you don't know, whether you have read, but they want that this is important in our daily practice, and therefore every pediatrician should be aware of it. So I think having some this type of the thing, examiner will frame the question, not just to assess our memory or something like that, right? So that's why these questions are kept. Let us go further even. Somebody say, chemoprophylaxis in children with asplenia. Dr. Chandresh, can you take it? What is the recommendation of chemoprophylaxis?
So chemoprophylaxis for capsulated bacteria,
Okay.
like Streptococcus and Meningococcus.
Yes.
For that, we can go for cephalosporin.
Okay. Always ask the question which organisms.
Yes, sir.
And then targeted that organism, there should be the choice of the antibiotic. Very rightly you said polysaccharide. And with the polysaccharide organisms, what is the drug of choice?
Penicillin.
Yes, Arti, penicillin, that's why. And then what doses and everything?
Sir, 125 mg, less than 2 years, 250 mg more than 2 years.
What preparation, Arti? Penicillin.
Orally, sir. Oral.
Oral also, which preparation?
Penicillin V. Penicillin V.
Yeah, penicillin. Very good, very good. Please, this can be the shortcut also in your exam. Even this chemopro or the vaccination or something, and therefore answer, please remember what is my point to you. Asplenia increases the risk of fulminant septicemia. Just fever, the person may die, and it has happened even adult. Mortality from septicemia is increased 50-fold following splenectomy in a case of trauma, that means healthy spleen, and 350-fold due to the sickle disease. So this is the, I would say, risk of the sepsis, which is major killer. And I think that seriousness should come to our mind whenever you face the patient of the asplenia. Indications, sickle, splenectomy following trauma, asplenic child with a malignancy or thalassemia, or even congenital asplenia occasionally, rarely. And particularly the drug doses, please remember, vaccinations are very important capsulated. We plan surgery for the splenectomy in a case of hereditary spherocytosis or even thalassemia or something. See that this 2 weeks these vaccines are given. For pneumococcal, please remember always the first thing conjugated pneumococcal. And here PCV 13 only, no choice. And later on, after the 2 weeks, you can go to cover more serotypes, that is the polysaccharide vaccine. And one more dose of the polysaccharide vaccine after 5 years. That is sufficient, that's all. And meningococcal should be given. So these vaccines are very important. Okay, and prophylaxis point of view, penicillin V, what we say. I think Capain, by trade name Capain, it is available. Difficult to get it. That is 125 milligram BD, less than 5 years. 250 milligram BD for more than 5 years. Duration point of view, people say that at least 5 years of age or 5 years after the surgical removal, whichever is longer. But ideally, most of the hematologists advise that it should be for the lifetime. After 5 years, chances are least. Chances are, I would say, chances decrease, but we don't know what percentage chances. So ideally, it should be for the lifetime. So I think this is the point which we should remember, being again the common condition for the pediatrician in the practice. I hope, is it right? Are you happy with what discussion we are taking? And I want these others also, which I am not able to see, please respond. Very simple questions also sometimes they take. With the suppose post
Primal duct.
Yes. Chinmay?
Yes, sir. Necrocystitis looks like necrocystitis.
Yes, it is the necrocystitis. Question is, what is the primary etiology? Why the child develops so?
Lacrimal.
Again, this is common question mother will ask you in the postnatal follow-up. That's all.
Lacrimal agent.
Yeah. Yes, somebody?
Lacrimal agenesis. Lacrimal duct agenesis.
May not be agenesis, but obstruction.
Obstruction.
You know
Blockage
that
of lacrimal ducts.
yeah, you know that this duct is there. The patency may not be maintained. And the obstruction will be there. It is blocked. And therefore, commonly they will complain of either the conjunctivitis or even some watering of the eye, the newborn period. And that is due to the obstruction. And if it gets infected, it may come in this way, the cystitis or even abscess formation. And therefore, this congenital nasolacrimal duct obstruction, actually treatment point of view, you know that local antibiotic drops and nasal duct massage. That massage, somebody will ask in the exam that how will you do? Your nail should be cut, and from this medial angle of this your eye to this gradually the nose, the anatomy of this nasolacrimal duct, you should press it so that material will come out and the patency will be established. So that nasolacrimal duct massage, I think that we should know, and we should explain to the mother to do morning, evening 10 times. And if the abscess formation is there, of course, it requires the drainage and then systemic antibiotics. So this is simple, I will say, question, but you know that in the postnatal follow-up, suppose if you have seen the patient well baby clinic, occasionally you get this type of problem. Okay, now something in a different way. Some case scenarios. A 12 years old boy present with a sudden scrotal pain and swelling on the right side. The cremastic reflex is absent. Shivangi, what is your diagnosis?
It would be torsion of testes.
Are you asking or this is your answer?
Answer, sir.
Why? That is another thing why I am asking. In the exam, always answer affirmatively. This is my answer. Maybe wrong even, don't bother. Right, but don't show the examiner that you are in the dilemma. Right. Show your confidence that yes, this is torsion. Suppose may be wrong, no problem. Absolutely right. That this is torsion, right testis. Please remember, absence of cremastic reflex is a very characteristic. But nowadays, this will not remain silent. What other test you should do for confirmation?
Elevation. Scrotal elevation.
No, confirmation. I want to confirm.
Exploration, sir. Exploration. Only exploration.
Exploration, Chandresh, I will do later on. But suppose by chance, if it is not, it may be due to some trauma also. Okay, not necessarily torsion. Some maybe some trauma also. So you know, before submitting the patient for surgery, nowadays I think when we were, I was a student or I was junior AP, we didn't have the facility and we were doing. But now with the facilities available, so you should go.
Doppler.
Absolutely. Absolutely. Always go for the Doppler. That will give you confirmation of your diagnosis. And this is very important. You know, I always say it's a dire emergency. And what the treatment will decrease the survival of the testes? The time frame is very important.
4 to 6.
Okay. 6 hours. Very rightly said, 4 to 6 hours. What is the contralateral test is need further care. Suppose surgeon is doing the treating, but anything to be done on the opposite test is,
Fixation.
Prophylactic
or nothing is to
fixation.
be done because that test is healthy. There is no problem. Arti?
Sir, prophylactic fixation or because if one testis is torsion, there is increased risk of
Very
second
good, very
testis.
good, very good. I appreciate. It is the scrotal archaeopathy.
Idopaxy.
That is fixation, of course. But that is to be done because in this child, that means it is vulnerability of for the torsion is there. And next time again may come with some problem or complication. And once you have taken the patient for the surgery, I think by surgeon, always they will do. That is the scrotal archaeopathy to be done. Very good. I think this is dire emergency. And what is my idea? Suppose all of us are present over here. Those, even the students, if you remember, and if you get even once a while this patient and immediately react and save the testes, I think that is a great job on our part. So that is the idea of keeping the question, and I'm sure in the exam also, our friends examiners are asking. One more child. A 20 days old child presents with the staccato cough and sticky eyes. No fever. Child is not toxic. An auscultation of chest revealed fine crackles. Arti, what is your diagnosis? Are you able to think? It's a 20 days old child, that means neonate. The cough
Staccato.
is.
Staccato is the clue.
Srinivasa sir is giving the hint. It's given some
Now,
ideas, clues. Yes, Dr. Chandresh?
it's a viral infection short of some of them.
Okay. Anybody else? Shivangi, Arti, Dvicha, anybody? Chinmay is there. If I give you the idea,
Sir, can I give another clue, sir?
sir, please, you are there
In
always, sir.
staccato, there are two C's. One of the examiners will always give some help. So staccato, there are two C's. So I'm giving you.
Klebsiella brunette.
Yes, sir, Chandresh. What is in your mind?
This also starts with C.
Klebsiella.
Chlamydia.
Yeah,
Chlamydia, yes, yes.
absolutely, Chinmay. This sir is giving the hints and Chinmay caught it that, yes. And this is the point is, please remember, neonates usually they don't have the mature cough reflex. And therefore, cough is not the common manifestation in the neonates of the disorders. But once a cough is in the neonate, consider that it is a significant condition, some serious condition. And which are they? Please remember 3 or 4. Number 1 is even the pertussis, whooping cough. Always keep in mind pertussis. Even infection point of view, second is the chlamydial infections. And even third is the aspiration syndromes. That may be due to the TO fistula, maybe even due to the GRD, or maybe even due to the incoordination of muscles of deglutition, functional problem. The point is, I think cough in neonate is very, very important. And here it is the chlamydial, that is pneumonia. You see, in the X-ray, what you will get? Hardly very specific. Some hyperinflation with minimal interstitial or alveolar infiltration. And what is the choice of antibiotic? Arti? In a chlamydia, what is the choice of the antibiotic? Yes?
Macrolides.
Macrolides, absolutely. And therefore, always, whenever you want to go for the antibiotic, ask the questions to yourself commonly. Is it indicated? That should be the first question. Try to find out the indication. Suppose indicated, then what is the likely organism? If you are not confirmed organism. And according to that organism, targeted to the organism, your choice should be there. I think that should be in our routine practice. With the azithromycin. Okay, one more case scenario. And I think very important nowadays what most of the examiners ask you. A 7-year-old boy has been diagnosed as nephrotic syndrome. admitted in your unit, already diagnosed, confirm everything. You just been started the steroids, and even patient is showing the response. Now parents are asking for the discharge. You are ready for the discharge. Arti, you are on call. You have filled up the discharge of this patient. How will you counsel to the parents?
Sir, every day morning.
How they should manage and they should take care at home?
Sir, at home every day they have to check morning sample of urine for proteinuria unless it is negative for 3 consecutive samples. Regular dose of steroid treatment. Child may eat more or there is weight gain due to steroid treatment as well. If there is significant infection or sudden weight gain or again there is appearance of edema, they have to check protein and come back to the hospital.
Okay. No, here I use the word counsel, that you have to do the counseling. And this is somehow very common in the DNA examination,
Yes.
OSCE station. Most of the conditions like nephrotic, febrile seizure, cerebral palsy, epilepsy, bronchial asthma, something like that, where probably counseling is very, very important. Routinely we do, but here in this situation, and therefore pertaining to your condition, how you should counsel to the parents. That exercise now, even NMC also insisting to every examiner that your training should be there and you should ask in the exam. Even in the MD examination nowadays, I'm sure that some examiner may ask you, in the case of some nephrotic, you have got the short case at the end of discussion. The examiner will say that how will you counsel to the parent? That's why purposefully I put the question over here. Anyway, I will give the idea, and please remember,
Yes.
for any such condition, this is one example I have taken, but in some other conditions also they can ask you. Number very important always, methodologically. Always introduce yourself. That I am Dr. Baldev Prajapati, I am pediatrician, and I am looking after your child. And then explain on the, they don't know what is nephrotic syndrome. So at least precisely in the simple language, try to explain them. That on the basis of the history, what I ask you, I examine the child, and you know that during your stay already we have done a lot of investigations, and we came to the conclusion that the child is suffering from one renal disease or kidney disease, and we call it the nephrotic syndrome. And what do we mean by the nephrotic syndrome? That there is loss of the protein in the urine, and therefore that the protein is lost, the child develops the edema, and following the edema, all other issues start. So that's simply in short pathophysiology we explain in the simple language. And then you can say that the main statement, this treatment of this child is very important, that is the steroids. And you should not be afraid of the steroids. Of course, everybody is afraid. I am also afraid. But here, this is the main line of the treatment. And here we'll have to give it. So please, this is steroid, and you should not be afraid. Even so many other people may even give some, I would say, signal for this drug, but you should not be having any problem. Purposefully, with the understanding we have asked. And therefore, you don't stop it. Because they stop it. Somebody said, therefore we stop. Or somebody said the dose is high, therefore they decrease the dose. So all these points will clarify. Later on, you can explain the steroid. They're 6 weeks daily. We'll go for 6 weeks alternate. Meanwhile, very rightly, Arti was telling that steroid toxicity we should explain regarding the obesity and all other changes, hairs and everything. But you can say that once you stop it, all these things are going to disappear. They are not permanent. So, they will develop the confidence. And then you can say, but it is very important for you also to maintain the diary. Therefore, ask the mother to prepare this diary. And in the diary, what she can, I think what Arti was telling us, by the simple dipstick, the protein, you will say that you have the weighing scale, you can. Nowadays, your blood pressure instrument digital are available, at least if not daily, at certain intervals, twice a week or so you can measure, and put everything in your diary. And even the urine output that you can measure. And that will give you the idea. And all the results should be, and whenever you come back to me, please bring this diary with all the informations.
Can I add two more points, sir?
Sir, yes, please. Sir, please.
Yeah, immunization, pneumococcal, this thing is
Absolutely.
not already this thing they must take. And in the beginning, we will always say this condition is most of the children, they do well. They may have a few, this thing, you have to give a positive thing, but regular checkup is important. So
Yes,
because, the prognosis is much better than
Yes,
in
yes.
congenital nephrotic syndrome.
Yes, what sir said
We
is
have to give
absolutely.
a positive attitude to the parents. They
So
should
that,
not get
yes.
terribly worried.
Yeah, they will develop the confidence. Yes, sir, I have taken later on in this next slide that even some complications, by chance if the child has severe pain or vomiting, we are after the peritonitis that you can explain. Regarding the vaccination, what sir said, that this vaccine, because with the particular disease, they are immunologically weak and these infections are common. We are after this infection and we have the vaccination. So if not given, at least once we stop the steroids after 4 to 6 weeks, we'll go for this vaccination. That part is very important. And even as sir said, that nephrotic syndrome is in that way is not causing any permanent renal damage to most of the patients, and results are good. The only thing during that phase, we'll have to take the utmost care. And I think if you explain very rightly, you can say that any question to you from your side, you can ask me, even you can share the number. If any emergency, you can talk to me. I'm always with you. And once you say I'm always with you, that makes a difference. So what sir is making, I will say, point clear to us that increase their confidence. Ultimately, they should develop that, okay, disease is that, but manageable. And
So
second,
they should not go to other systems of medicine. Sometimes it can become dangerous.
yeah, absolutely. Later on, they steroid there for homeopathy and other pathies and alternative medicine. I think that also you can explain that people will advise you, but please don't go for other pathies. Even in our allopathy also, we have the limitations, but we know and we'll take care. And these are the medicines which we should give. I think here I've given one illustration of the nephrotic syndrome, but please, I want to sensitize all the students that prepare this type of this counseling in your notebook, write down regarding the common conditions. Suppose in a case of the cerebral palsy, in a case of epilepsy, case of bronchial asthma, in a case of even so many, even malnutrition on the discharge, that what you are going to talk, even in the anemia. So I think these are the things, just some few illustrations I have taken. Counseling is very important. Should
So
I?
may I add one thing?
Yes, Dr. Nair, please.
Yeah. In their exams, they have the last 2 minutes for counseling after the
Right.
long case.
Right.
And in that, what everything is listed very beautifully by sir. But remember one thing, counseling is not only what you speak, it's also your body language. So
Yes.
one more thing about the counseling, that give a comfortable sitting to the parent and sit at the level of eye to the parents. You should not be
Absolutely.
showing your superiority by standing or by telling them like that. So body language is also important in counseling.
Absolutely. I think Dr. Nail has added very, very, very important point. I think it should be in our routine. Absolutely. Most of the now ICUs or these hospitals, that they insist that there should be some provision or some, I would say, sitting arrangement, that when you are talking to the parents, even before that, it's all right that I may not know the details, but you can ask that not only the parents, some grandparents want to attend, or even some nearby relatives, all of them, they should come together, so that probably you can explain them, and even you may not have to repeat repeatedly, because then somebody else will come. So I think these are some points of principles.
One more thing, transport facilities are given by government in such
Yes, yes.
patients. So certificate is there, they can have free travel, this thing.
I think this is also very important what sir said. Absolutely, absolutely. So I'm sure that the student will prepare it, this type of the counsel. And I think now it is very common question, and it is expected that we should be the at least average counselor, if not good counselor. But everybody should be counselor. That is very important. Anyway, let us go further. Very simple question. Arti, very simple. Intramuscular question. Preferred sites in intramuscular injection at different ages.
Sir, anterolateral aspect of thigh till 3 to 4 years of age, and
Right?
after that, deltoid is preferable site
Very
for
good.
intramuscular
Very
injection.
good. Very good. You know, infants, middle third of the anterolateral aspect of thigh. It's a middle third. How will you decide the middle third, Arti? Any idea, or somebody else? Shivangi?
So we measure the distance between the knee and the hip joint, and then accordingly we divide it into three parts.
Shivangi, if I remind you the first MBBS, they say that go for the anatomical landmarks.
So ASI
You are
is
given you are given the landmark, but very big, knee and this hip. So very wide areas. You know, one particular anatomical landmark.
so ASIS and
Okay.
knee.
So ASIS and tibial tuberosity.
Sorry.
ASIS and tibial tuberosity.
You know, another thing, you are talking over here anterolateral aspect of size. So both the points should be laterally. Tuberosity will be medially.
Femoral condyle and ASIS.
Yeah, lateral condyle. So, you know, the very simple question, but the people are going to ask you. And you know why I'm asking the question? Tomorrow you are going to go for the vaccination in a private. You should note when the DPT should be given. Most of the times when we get the problems, probably it is not the proper site. And therefore, the middle third of the anterior aspect of thigh and older children, here it is written more than 3 years, but usually I prefer more than 5 years, deltoid. And gluteal region is not preferred. Shivangi, why? Why it is not preferred the gluteal region?
There is a sciatic nerve.
Particularly for certain vaccines, if I tell you. Anybody else? Dricha, Chinmay?
Gluteal region has
Sorry.
a high muscular muscles are moved into gluteal region, so high blood supply. So that's why.
Dricha, if I remind you, the gluteal region, muscles are not more. On the contrary, fat is more. Am I right? Anatomy.
Yes, yes.
So what?
Sir, in children, certain children, when they're normally developing, the muscle mass in the gluteal region are not much developed because they are not, they are just like starting to walk and starting to stand. So these muscles are not developed. And the second thing is sciatic nerve. There is risk of
Okay.
injury to the sciatic.
I think that you know that the upper outer quadrant is safe particularly for that. But of course, sciatic injury is one of them. With a small area, you don't know. But if I remind you, I think gluteal region is having the more mass. May not be the muscle mass, but the mass is more. The point is, please remember, I think being pediatrician, all of us should know. Which particular vaccine, suppose by chance somebody has completed the gluteal region, we will consider that nil effect. And that's the reason. Which at least two vaccines, almost every vaccine, but two vaccines they have proved even that if you have completed the course, the result is 0. If you are given the gluteal region. And that is hepatitis B and anti-rabies vaccine. They have done the study, they have even put it on record, and therefore, if many a times when some remote place authorities, it may get the person that hepatitis B completed 3 doses, but on the gluteal region. And if you go for even the antibody titer, you may get negligible or 0. And therefore, any vaccine, as such, any injection now, should not be given on the gluteal region in children. And particularly hepatitis B and anti-rabies vaccine, they have found that in spite of the complete course, complete schedule, the antibody titer is negligible or 0. And therefore, suppose if you come in the practice, somebody has completed over the gluteal region, don't count it. Right. So that is the point. That's why I wanted to discuss with you. And which muscle is targeted in intravascular injection, anterolateral aspect of thigh? Dr. Shivangi?
Vastus lateralis.
Which was vastus lateralis. Why in the vastus lateralis? There are three vasti.
By
Vastus lateralis, intermedia, and vastus medialis. Suppose somebody goes medially, what can happen? Little bit. That
There is risk of injury to the femoral in the adductor canal, femoral Hunter's canal.
if you go for the middle one, usually the structures are safe. But the problem is, you will inject the fascia lata, and fascia lata is relatively avascular structure. On the contrary, it will not be absorbed and will cause the chemical irritation. It will result in fibrosis and sometimes shortening of limb. So that's very important that we should be vastus lateralis. Therefore, and regarding this, how we will decide, I think I have come this place, anatomy, anterolateral thigh mater, middle 1/3 of the between the greater trochanter and the lateral femoral condyle. Middle 1/3 of the line between the greater trochanter and lateral femoral condyle. I think daily lots of injections are going on in our hospitals. But if you ask precisely, if somebody is doing, I think we should be happy, but hardly precisely is done. And once this thing is there in your mind, when you are giving the DPT vaccine, the problems will come down. Somebody says the good hand, but I think hand is not, nothing is hand. Everything is in mind. If it is in mind, then in the hands it will be good. And deltoid, what is the place? Midway between the acromial process and deltoid insertion. And here, that's why you may not get the circumflex branch of the axillary nerve. Therefore, it should be midway between the acromial process and deltoid insertion. Again, I think for the basic, some Viva table or some examiner, they ask these questions. Anyway, coming to this another case scenario. A 6-year-old child presents with muscle cramps on exercise, with even urine test positive for myoglobinuria, because color of the urine is getting changed. CPK is raised, somebody investigated, and it is more raised particularly after the exercise. What is the condition? Anybody? Aarti, Shivangi, Chandresh, Chenmay, Drija, I think others are not able to see, but there.
Rhabdomyolysis.
viral myositis.
Sir, myocardial disease.
Rhabdomyolysis.
Rhabdomyolysis due to what? This is a very chronic condition. It is not viral for a few days or so.
Sir, is it myocardial disease?
Absolutely, absolutely, absolutely. Very good, very good. This is myocardial disease, type 4 glycogen storage disorder. Very few patients have been reported. Suppose somebody asked me, I have seen only 2 patients. One during my, I will say, early as a junior person. But this patient, classic muscle cramps and change in color of the urine. And then if you go CPK and everything, then you will get the answer. But I think scenario is very important. And what enzyme deficiency? I think this is a NEAT or NEXT or whatever you give the pattern of exam. All these questions they are asking in this way.
Muscle phosphorylis. Muscle glycogen phosphorylase.
Very good, very good.
Myophosphorylis.
That is the muscle phosphorylase deficiency. Absolutely. And another, suppose if you are able to answer in the exam, somebody will ask the question, name the type of this disorder presenting with hypertrophic cardiomyopathy in infancy. Disease. Yes, Shivangi. You said
Pompe disease.
absolutely, absolutely, very good. There is Pompe disease, there is type 2 glycogen storage disorder. It's a similarity of the disorder. Presentation is different, age is different. So I think if you know this, I'm sure that what I want to sensitize you, that prepare your MD examination to score the highest, not just to pass. And therefore, starting from the simple intramuscular injection, to all the vaccination, to the counseling, to the metabolic disorder, to even the advanced pediatrics. Right. Some of the, I will say, illustrations are taken to sensitize all of you. Okay. Another question, very now basic. 18 months old child present with severe pallor. Take the history in details from the mother. Once I was talking to the hematologist and they said in the DM hematology, I am asking this question to every student because it is very important. If suppose child of the anemia, severe pallor has come to you, then what points you will ask to the mother, how will you gather the information? That is very important. Let us try. And these are the questions people are asking. I will search in a case of even in a short case, long case anemia, they will ask you.
Starting from birth.
Take one by one. Yes, Aarti, start it.
So starting from birth history, whether the child is full term or preterm.
Very good.
After that, feeding history, whether the child was completely on breastfeeding. After 6 months, we'll take maternal history as well, number of babies and maternal conditions.
Yes.
After 6 months, whether the complementary feeding was started appropriately or
Sorry, Aarti, I am interrupting you. Why are asking in maternal status? In what way it can affect the baby?
Sir, if mother is anemic or if there are history of multiple babies, then there are chances of low hemoglobin in babies from birth as well.
I think you must be knowing that if the mother will go for a severe degree of anemia, but may not be develop the problem to the mother. But one condition, yes, that is always reflected in the baby. That's why I'm asking you. I'm interrupting you. Sorry. But if you know that condition, that one variety of the anemia in the baby or in the infant, the etiology is with the mother. That mother is deficit with that which is reflected in the baby. If I give the clue, it is not iron. What else?
Vitamin B12.
Yes, B12.
B12.
And it has been found that our mothers are deficit, which is reflected, and therefore you may get infantile tremor syndrome or megaloblastic anemia, probably due to the severe deficiency in the mother. Particularly if you go even the maternal, and therefore they say that infant then go for the maternal investigations also. Anyway, Aarti, go ahead. Sorry for interruption. I thought that
no, sir. Yes. After 6 months, feeding history and complementary feeding. After that, we can ask that also if pallor is appeared suddenly or after certain age, like baby is 18 months old, whether the pallor has been noticed by mother by 9 or 10 months of age. So we can rule out some hemoglobinopathies,
very
suspected
good.
hemoglobinopathies. And
Fine.
that's it.
Some other points. Anybody else? Aarti has started, I will say good points.
Sir, any history of transfusion in family?
Very good. Transfusion. Absolutely. History of transfusion in the family. Very good.
Sir.
Dr. Chandresh, how it favors? Suppose if it is there, what does it indicate?
Yes, sir. We can think about some if they are regular transfusion in family, like some sibling having regular transfusion every interval, then we can thought of some hemoglobinopathy or thalassemia kind of things.
Okay.
And if they are taking like once one time sibling having transfusion on one time history, like we can think about some nutritional deficiency also.
Okay.
And
is there any other hemolytic anemia where infrequent transfusion may not
sickle
be
cell
one?
Sickle cell.
Sickle cell
Okay.
anemia.
Sickle cell, anything else? Anyway, but history of transfusion is very important in the family. Very good. Or in the child itself. Okay.
Yes, sir.
Anything? Any other information?
Sir.
Socioeconomic status of family.
Okay.
Development history. We can think about that.
Okay. In what way it will be useful? Developmental history.
Sir, vitamin B12 deficiency, there will be neuroregressions. So
very good. Very good. Fine.
And,
to save the time, to project the slide. Always, as we discussed, ask about the onset of pallor. Onset is very important. Suppose sudden hemolysis, maybe the G6PD deficiency, or malaria, falciparum malaria, something like that, sudden, gradual, the nutrition or some others. Dietary history is very important, what you and all of you discuss. Is he suggesting worms? Always we should ask, history of worms in the stool, right? That is very important in our country, or I will say developing countries. It is one of the factors. History of bleeding is very important so that you can find out the blood loss, right? Blue spots or something. Sometimes even that blood in the stool may be the cow's milk allergy or any drug. That is very important. Long term, suppose aspirin in a case of Kawasaki. Associated symptoms are very important. Fever, weight loss, toxic loop, maybe in a case of leukemia. As for the jaundice, that indicates some hemolytic process, right? Even transfusion already you discussed. Similar history in the family is very important. And at least the community, some of the communities are having the specific, for thalassemia, all of see, even scheduled tribe, particularly the sickle. So that is very important. Consanguinity, autosomal recessive disorders, in the consanguinity is common. Geographical distribution is also very important. Even in Gujarat, that Rajpipla, Chota Udeipur, these areas, even the sickle is common. Or even suppose eastern part of our country, maybe the Kalas are. So family background is very important. So the point is, you will gather this information and simply from the information history, if you analyze so many points regarding the anemia, you can decide. So that's the, I would say, point what the examiner wants. That in a given some symptom, given some scenario, that is they want that whether the skill of deriving this data. That's the point. And I'm sure that these type of ASCII stations are always kept. Even there in our MD examination, they are asking in the Viva, or suppose some of the case of anemia if there. So this is just, I would say, illustration that how you will go for details of any symptom. Sir, anything from your side, Srinivasan sir? Okay, similarly, explain for urine sample collection by clean catch in the midstream. Dr. Shivangi, can you take it?
Sir, we'll
Again, that this is very common in the practice. That's why I ask.
Sir, we'll advise the relative to collect the early morning sample, the first urine that the baby passes after getting up in the morning. And we have to ask them to hold the sterile container a little away from the genitals. And after some amount of urine has passed, after that, they have to collect the urine in the container. And it should not be touching any body part. It should be away from the genitals.
Okay. Anything else? I think very important point Shivangi missed from the beginning.
Yes, sir.
Sir, we should wash the
Parents should
genitals
clear
with
clean hand,
Okay.
clean
we
hand
can
hygiene
ask
and
Anything else to the baby?
wash the area with plain water and without any antiseptic or
Okay. And this is somehow, I will say, that part is lacking in our counseling. The parents don't know that how they should do. And later on, whatever the culture reports we get, they are not reliable. Probably these are there and our interpretation is wrong. Therefore, we insist that every clinician take some time. Just don't simply offer the container to the mother and ask her to collect the urine and to send for the culture. But what we should do, genitals should be cleaned with soap and water. No antiseptic, I would say, solution should be used. Explain. Some of the, I would say, obsessive mother, she will use so many antiseptic solutions. So tell her that it is not required. And even the forcefully preputial skin should not be retractile. Easily, whatever the retraction is possible, okay, you may do. But don't do forceful retraction. Second, child is asked to squat. If older child, that is good. Because squatting position, what Shivangi said, automatically many points that touch the body part or genitals and everything will go away. So that squatting position. As I said, retract is in the males and separate the labia in the females. And then ask to avoid the urine. And initial part where rightly Shivangi said that that is to be discarded. The mid part of the urine stream should be collected. Sterile container, which is very important, what she said. And plating of the urine specimen within 1 hour of the collection. 1 hour of the collection. And by chance, if you are not able to manage due to some reason or odd time, the sample should be preserved in the refrigerator, 4 to 8 degrees centigrade. Then here somebody will ask the question, where the blood culture should be kept? Shivangi?
Sir,
Urine culture you said in refrigerator, but where the suppose you have collected the blood sample for blood culture for the sample for the blood culture, please.
It should be kept in the incubator actually, ideally.
But you know Shivangi, every time it is not possible. Suppose what time you have collected that midnight, right?
sir,
Immediately microbiologist may not be available.
so blood culture should be kept at room temperature only.
Why, Aarti? Very
Because
why?
bacteria grows maximum at room temperature. For urine, we want not to grow outside or other bacteria, contaminated bacteria to grow. That's why we are
Very
keeping it
good.
at 4 degrees Celsius.
Very good. Please remember one principle. Any sample, any specimen is expected to be sterile. They should be kept at room temperature. Blood culture we are expecting sterile by nature. If it contains some organism, it is pathology. CSF by nature it should be sterile. Therefore, any sterile sample, if you want to send for the culture, they should be kept at room temperature. If the organism is there, let them grow. We don't want to inhibit their growth. But if there are chances of contamination, like urine, contamination is possible, then don't allow this contaminant to grow and therefore keep in the refrigerator. This is the basic principle of this culture. Very important, and sometimes that's why examiners are asking in the exam, because this part is in our daily practice and somehow training in our residency. Basic principle, as I said, any sterile specimen which is expected to be sterile in the body, and if you are sending for the culture, they should be kept at the room temperature or in incubator immediately. What Shivangi answer is right. But if you are not able to manage, the room temperature, and some contamination is possible, then kept them in the refrigerator. So that by chance contaminant organism is there, we are not allowing them to grow. And pathogen in the incubator, they will grow. So this is basic principle, and I'm sure that please, even in the ID fellowship, sometimes I have seen infection disease fellowship that the people are not aware of it. And I want that you should be fully aware of it. I'm sure that this is again one illustration, but you should know that therefore will ask related to this. Okay, let us go further. Ultimately they want to some cases that how much you have worked in the pediatric, how many cases you have seen, how much you have read, Shivangi. They want to assess all of you. And therefore they will ask these type of questions even in the DNB or even the I will say RMD examination. Here the child presented with the 15 to 20 per day. It's a new, I would say younger the baby. And water is stool since birth. He was full-term baby with birth weight 2.9. That means birth point of view, no problem. Full-term weight was 2.9. And now due to this water stool is found with a severe dehydration. There is hypokalemia, hypochloremia, and metabolic alkalosis because EBG with electrolyte was done. What is your diagnosis? I think somehow everything is there on your slide. I don't know how it has come with the only one click. Not so common, but yes, uncommon case. Suppose somebody is having the good, I will say, scoring, then examiner may ask the question. It is the chloride losing diarrhea. If you see the Nielsen, only one paragraph is given. But I know at least some of the examiners, and I have seen at least 2 or 3 cases. Chloride losing diarrhea. Basic problem is transport mechanism of chloride or bicarbonate to the distal ileum and the colon. and maternal polyhydramnios may be there if you ask in the history. So this is just one case scenario to sensitize you for uncommon condition. I think upper part is cutting in my laptop, so I'm not clear. I don't know how I should do it. But here scenario is clear that this baby was having this past history of the prolonged umbilical stump bleeding
Factor 13, sir.
and delayed separation of the umbilical cord.
Factor 13, sir.
Okay, very good. I think prompt response, immediate response. And that is factor 13 deficiency, absolutely right. Next questions I will ask, what is the another attention drawing clinical manifestation of the disease after surgery? Somebody has done surgery. Nobody knows that this condition is there. But many times I remember one patient at the LG, we diagnosed with this type of history. After surgery, what problem you are facing? Surgeon is facing that my surgery was good, there was no problem, but I don't know why this complication is there.
Delayed bleeding, sir.
Okay. Fortunately, here bleeding was not there.
Delayed wound healing.
Very good. Very good. Shivangi, absolutely right. Poor wound healing. I remember this in the LG hospital almost 15 years back. I was there, and one of my resident told, my resident was in the pediatric and his roommate was surgical resident. And they were talking that we have one patient, sir, and the good surgery, no problem. But wound is not healing since almost 6 to 8 weeks even. And we don't have any other clue. And therefore, the pediatric resident told me that, sir, they are going to refer to us. I said they should refer to us. We got it and that turned out to be the factor 13 deficiency. Poor wound healing. Very good, Shivangi. Please. I think all of you are well prepared. Chandresh and Arti and all of you, I think. Very good. What observation is the basis is for deficiency of this factor? What Dr. Chandresh?
Expedited.
Instability of the clot. And what pattern of hemorrhage makes the clinician to suspect? Very important, Chandresh, what he said initially. Delayed hemorrhage. What
Delayed.
trauma is on suppose Saturday, but it starts on Sunday. Bruise or hematoma. Sir, immediately there was nothing. But now it has started. If any mother or any person complains in this way, please keep in mind. I am sure you will get it during your career, provided you are aware of it. So these are the important, and therefore you know what the people say, that in investigation test may not be anything, but you are a good clinician, you can catch the diagnosis. And these are the few examples. And when you are at the good scoring, I think somebody is going to ask you. Define the delayed separation of the umbilical cord stump. Sorry, it is a stump, some mistake. Dr.
More than 14 days.
Chandresh?
More than 14 days, sir.
Absolutely right. You know, commonly 5 to 7 days. Commonly, there is a time for the fall of the umbilical cord is 5 to 7 days. But to say exactly the delay in 4 weeks' time, that we should know. Anyway, a 3-year-old girl was referred for precocious puberty and obesity. And she also had gelastic seizures. I hope you know the gelastic seizures. What is the most possible cause of precocious puberty in this girl, Arti?
Hypothalamic.
Yes, Chandresh, you said something?
Hypothalamic
Hypothalamic?
hamartoma.
Hamartoma, absolutely right. And you know what do you mean by the gelastic seizure? What do you mean by it? What are the seizures? Tonic, clonic, twitching of face, rolling of eyeballs. Shivangi, what do you mean by it? Arti, any idea?
That also you can give us a multiple choice question.
Sir is helping the students. But one very important option I have not kept it. Anybody? I'm sure somebody will.
Laughs and
Somebody is going to speak. Anyway, please remember.
Laughing. Bhau.
Yes, absolutely, absolutely. Unnatural crying or laughing.
unnatural emotional bursts, especially laughters and.
Yes, yes, absolutely. Good clinician will just suspect this hypothalamic hematoma from that. And you look at the child that's presented with the precocious puberty. What are the other clinical manifestations of this disorder? Diabetes insipidus, hyperthermia, cachexia, related to hypothermia. Sorry, hypothalamus. All these problems can present, all of you know. And what type of sexual precocious is known in this disorder? Hypothalamic hematoma. What type of
Isosexual.
isosexual? Absolutely right. Absolutely. Very good. Very good. I think good responses I'm getting. But I want there will be involvement of more students, not only 5, 7. I thought that even 10, 15, 25 multiple responses should be there. I'm sure if we continue in the future, there will be more responses and more participation of the students. Anyway.
Your efforts will not be wasted, sir.
Thank you, sir. Thank you. A long-faced 10 years old mentally retarded boy presents with prominent ears and large testes. I think diagnosis should be obvious.
Fragile X syndrome.
Sorry, Chin, what did you say?
Fragile X.
Absolutely. Fragile X syndrome. And not so uncommon. What causes the feminization of these boys? Which enzyme that means? Excessive aromatase. And name of other two conditions associated with testicular enlargement. Here testicular enlargement is the important clue. Similarly, in some other conditions where testicular enlargement may be the important clue. Here, long face and testicular enlargement very sufficient, I will say, to see the fragile X. But are there other conditions where this large testes becomes the important clue to catch the condition?
Clean filters?
No. Arti, anything else?
Excessive growth.
Please remember, if you are not aware, difficult to predict. Hannux congenita and lymphatic tissues.
Okay.
Actually, these conditions may initially present as a large disease. Maybe the important, I will say, clue or complaint of the parents or the patient. From that, you may go for other features or something and you may get it. A 7-year-old boy presents with repeated episodes of non-pitting edema and abdominal cramps. And his parents are told by some previous consultant that the child has immunological disorder. What is it?
Extraordinary.
Sorry?
No.
No problem. You can answer. Maybe probably some other condition, if not for this condition.
Extraordinary syndrome.
Answer is C1 inhibitor deficiency. Complement 1 inhibitor deficiency. Open the Nelson, very nicely described. And at least I think I have seen 3 patients who had this problem. And what complication can be fatal in this condition? That we should know if you are the patient.
Meningitis.
What is the fatal complication? Sometimes in lighter mood, Dr. Chandresh, what I answer to the students, that if I ask the question and the wrong answer, then I am getting the answer for 2 questions. Now, one, which I ask that you don't know, and second, you answer, that is the answer of which question that you don't know. In the lighter mood I am talking.
Yes.
Complication. Laryngeal edema. That is going to be the fatal. And which other disorders have been reported in these patients? That is the C1 inhibitor. What other problems can develop? What other conditions can develop?
Neisseria infection.
Neisseria, that's why that is with the C complements 3 deficiency.
Yes.
Not 1. That is complement C. That's why I said that what you are answered, that should be with the C3. Conditions, SLE, and even glomerulonephritis are known to present with in a condition of C1 inhibitor deficiency. So therefore, on follow-up, if you see, sometimes they may go for the SLE also. Is there any other condition which in the follow-up may go for the SLE? It reminds me. Another condition. Here we said C1 inhibitor deficiency. It may develop the SLE. Similarly, is there any association has been found that you have diagnosed this condition today and may come with the SLE after a few years? Or you should keep in mind on follow-up, which is that condition. It is related to the lymph node disorder. Let me give you some idea.
Lymphoma, sir.
Not the simple lymphoma. It is considered the benign condition, but may go for these type of the complications. And the name is derived from the Japanese name. The name of the condition is derived from the Japanese name. And if I just tell you the more information, just I think 4-6 months back I visited Japan, and during that our tour, when the person told regarding the name of that place, I said, is it the same name of the place? He said yes. The name is derived from the place in the Japan, and that is Kikuchi Fujimoto disease. Kikuchi, the name of the village, and Fujimoto, the name of the person. And Kikuchi Fujimoto disease, commonly present with a fever of longer duration and lymphadenopathy. You don't have the answer. And lymphadenopathy having some characteristic which you can say histopathologically, it is the Kikuchi Fujimoto disease. And these patients, if you go for long-term follow-up, some of them may go for the SLE. Dr. Vijay Evle has one patient. So I think these are the things which we can learn. Anyway, I think somebody said lymphoma, so now the question on lymphoma. A known case of Hodgkin lymphoma present with sudden onset of cough, dyspnea, harshness of voice, stridor, facial edema, and drowsiness. All these problems develop within few hours. What is this complication? I think those who are working in the hematology or oncology, they may come across such emergencies.
Sir, could be tumor lysis.
Sorry, Chinmay?
Sir, could be tumor lysis syndrome.
Okay. Tumor lysis syndrome will present with something else.
Sir,
Sir, maybe catecholamine release something. I'm not sure, sir.
Okay. If I remind you, it's an anatomical problem. It's a
Superior vena cava syndrome.
Absolutely, it's a superior vena cava syndrome. Because enlarged nodes, they are pressing over the nearby structures. They present in this superior vena cava syndrome. And what are the life-saving? Immediately, they say chemotherapy and radiotherapy. Okay, one more question. I'm sure that whatever the time we have, we try to utilize in the best way. This child, 2 months old, present with marked respiratory distress since birth. And this is the chest X-ray. I hope you are able to focus. My questions. What is your diagnosis? Still you can see the picture. That's why I kept even the picture over here also. It's a malformation. It's a congenital malformation. I'm giving the hint because it is since birth problem is there, breathlessness.
Congenital lobar emphysema.
Absolutely, absolutely, Shivangi. Why you were also so silent? Congenital lobar emphysema of the left side. I don't remember, but I think now the name is changed. Some terminology changed. Please verify in 21st edition of Nielsen. They have changed the name. What is the most common site?
Left upper zone.
I think which is over here. That is the left upper lobe. What is the line of the treatment? Excision of the affected. Please remember some of the conditions. Left upper lobe, most common congenital emphysema. Here you can see the lobar emphysema with even pushing this mediastinum opposite side. Sometimes you may get even the lung hernia also. And most common site is left upper lobe. Suppose if you get the persistent, even the recurrent pneumonia in the left lower lobe, always exclude the pulmonary sequestration, because that is the most common anatomical malformation for the pulmonary sequestration. And if you get something, this right middle lobe of subcarinal, persistent some opacity, or responsible for recurrent pneumonia, persistent pneumonia, that may be the bronchogenic cyst. Bronchogenic cyst. And if you get the patient with complaint of difficulty in swallowing, posterior structure, congenital malformation, pressing over the esophagus, that is neuroenteric cyst, or even the neuroblastoma. So the point is how the patient presents. If you consider the congenital and with the manifestation and anatomical location, you can consider, and most of the times we are right. This is the just point to give you one more child. 9-year-old girl with high-grade fever of 4 weeks duration. It was diagnosed as brucellosis. She started to deteriorate. Actually, the patient started to improve initially, but then suddenly started to deteriorate. With high-grade fever, pancytopenia, which was not initially. And this is the bone marrow aspiration. It confirmed the diagnosis. Even it is shown with the arrow, which was the diagnostic. You should be able to interpret it. Fever, developed the pancytopenia, and even the lymphadenopathy, and even the hepatosplenomegaly. And bone marrow confirmed the diagnosis. It was following some infection, but it is known following the dengue. It is known following the enteric. It is known following even tuberculosis. And that is secondary to these infections. This is not a common complication, but known complication. The question is, name the condition.
Hemophagocytosis.
Absolutely right. That is the hemophagocytic syndrome, hemophagocytosis. It's an example of dysregulated immune response. Certain conditions, HIV is an example of immunosuppression. Severe acute malnutrition is the example of immunosuppression or immunodeficiency. Here, it's an example of particularly immune dysregulation. Hyper IgE syndrome is an example of accelerated immunoresponse. So in normal immune response, when it goes for change, hyper, hypo, or dys, various conditions can present that we should keep in mind. That was the point. Suppose if you're suspected, what are the blood criteria from which you can diagnose before board?
Ferritin.
Anything else? Very good.
Yeah.
You should remember, I will say,
Ferritin.
in the Nelson, there is one table is given.
Ferritin level.
Ferritin level.
As one is the triglycerides. Triglycerides will be raised. Fibrinogen will go down. And ferritin, people say more than 5, but most of the hematologists say that will be in thousands. That is very correct. Not marginally raised ferritin, but sky high. Why there is decreased fibrinogen? And due to the decreased fibrinogen, what you will get in a case of CBC and other acute phase reactants? Here the condition, if you suspect that ESR is going down and CRP is increasing, then also you can suspect that pancytopenia. Suppose previously you had done the ESR, now ESR is decreasing, but CRP is increasing. ESR is decreasing because fibrinogen is decreasing. Because for ESR, for rollover formation, fibrinogen is required. And once the fibrinogen goes down, ESR will go down. But due to inflammation, CRP is increasing. Similar one term, please remember, in a case of suppose if you are suspecting some collagen disorder, ESR is going up and CRP is going down or remains normal. That means a case of SLE. With the inflammation, ESR is going down. But it is said that in SLE, gamma interferon channel, which is responsible for the C-reactive protein synthesis, is affected or blocked. And therefore, CRP is not increasing, but ESR is increasing. So any collagen disorder, if you come across with ESR is increasing, CRP is remaining normal or going down, it is SLE. And once you see, one that is another thing, any collagen disorder goes for the complication where ESR is going down, CRP is increasing, that is macrophage activation syndrome. So I think that's the thing that how clinically even and routine investigations you can suspect. Name other conditions, I think, okay, I have kept over here with autoimmunity, the macrophage activation syndrome. I think these are the things not uncommon in our daily practice. In the PISU patients, when you see these problems, complications, try to analyze. I'm sure that you will get it. One more X-ray. 5-year-old child brought with complaints of cough and chest pain. There was no fever. And this chest X-ray was taken and sonography confirmed the diagnosis. What is it? This is the real patient which I got from Jamnagar.
You are not giving a clue?
Yes, sir. Sir is always there to help the students. Question is, name the condition. You can see the picture over here also. What these shadows are there? Multiple shadows, both sides.
2 balloons.
Sir said balloons or rounded shadows. And they, if I say it, they are not congenital, they are acquired. Okay.
Sir, is it bronchogenic carcinoma?
You know, bronchogenic carcinoma, number one, is not common in the pediatric practice. Second, bronchogenic carcinoma, if at all, you know, what is the most common site which I remember from the MBBS student, MBBS? Most common, more common in the adults. Bronchogenic carcinoma more common in the right upper zone. And that's why we used to say Pankos tumor. If you remember Pankos tumor. Somehow, pediatrics, I think, not more common. This is not that unusual. This condition can happen in pediatric children and this can happen in adults also. And so somehow it is more common in the coastal area, they say. Therefore, I said Jamnagar. And absolutely. It took some time, but ultimately came with the correct answer. It's a hydrated cyst. Some more questions people may ask. You know, if I in sonography.
He has told I was going to give the second clue. Some animal in the house.
Why is it sonography confirm the diagnosis? That means sonography, what further the person could appreciate?
Air fluid level would be and Scolex present.
Scolex will be present in where? In which condition? That is another, not in this.
No, sorry, that is.
That's seriously.
Yeah, Scolex you will get in a case of?
It is cysticercosis.
Cysticercosis. So here, similarly, what else you will get it? Your point is not that wrong, but something else you are able to see. Similarly.
Sand lesion, sand powder. Something.
Okay, maybe.
Daughter cyst.
Absolutely, Shivangi. Daughter cyst. Even you can see the multiple some daughter cyst, these sonologists can appreciate. Very classical. Nowadays, when we were students, all these facilities were not available. It was difficult for us. And you know, blindly, one should not do the puncture. Suppose somebody doing the puncture, what can happen? If the person does not know and by chance he has put the needle, What problem can happen? This was happening, I will say, when sonography was not there. Occasionally, rarely, but yes, it has been reported. Suppose this cyst is somebody puncturing, what can happen to the patient?
So it may go into prolapse, anaphylaxis.
Anaphylaxis, absolutely. And therefore, during the surgeon will take care that it is encapsulated intact. He will take that care. This is very important. But nowadays medical therapy is available. What is the medicine? Nelson has given, very nicely given, more details given. And even one of our late Chief Minister of Gujarat was treated with this medicine many years back by All India Institute of, I would say, Delhi, AIMS Delhi. Remember, our Chief Minister of Gujarat, late, now he's no more, but he had this multiple hydrated cyst and he was treated with the medicine. Which medicine? I think paracetamol is the common medicine. Paracetamol is the common medicine.
Albendazole.
Albendazole.
Okay.
Then albendazole, but what is the dose? Dose is not common. Duration is not common. And please remember, albendazole 15 milligram per kg per day in 2 divided doses, maximum 800 milligram per day should be given. And that should be given for 3 to 6 months. And I think if I'm not doing the mistake, probably some people have said that if no response, even you can repeat the dose. But albendazole works very well. When if it is not localized, multiple cysts, you cannot go for the surgery. In that case, the medical therapy is available. And name the causating agent.
Echinococcus
Granulosus. In way how it is classified, Echinococcus granulosus. Sometimes parasitology, Shivangi, your long case will be discussed only on parasitology. They will not ask anything on CNS. Suppose neurocystic sarcosis is the case, and then the discussion will go somewhere else. So here, what is the parasitologically they are classified?
It is a tapeworm, dog tapeworm.
Okay, very good. It is the cystod. If I remind you parasitology broadly, one is protozoa. In protozoa comes all these Plasmodium vivax, Plasmodium malariae, even Toxoplasma gondii, Melenterium coli, Giardiasis, even Kala-Azar, all these are the protozoa. Then cystodes, nematodes. In the cystodes, all this comes. Tinea solium, Tinea saginata, Echinococcus granulosus, H. nana, D. latum, all these are there. And then trematodes and nematodes. In trematodes are the flux, hepatic flux, Paragonobastrogamete, that is lung flux. And in nematodes, all the bumps. And they are the Enterostoma duodenale, Enterobus vermicularis, Ascaris lumbricoids, right? And then guinea worm, and then which are bankruptcy and lower, that is filariasis. I think this is just broadly classified, this parasitology. You can refer the Chatterjee. I'm not sure whether which one you are reading at present. But if once you have the idea, you can consider many things. In the D latum, what is the most common deficiency?
Vitamin B12 deficiency.
Absolutely, very good. But B12 deficiency, when people say, the medicine even, that even if you have got suppose repeated B12 deficiency, check for this D latum. You may get it. So the point is, if you are aware, you can get it. This is just to sensitize you. Okay, one more condition. Yeah, nothing new for the pediatrician. Okay, who said? Now complete it.
Staphylococcus.
Yes.
Staphylococcus scalded skin syndrome.
Scarlet skin syndrome. Okay. But for postgraduate, this will not be a simple question. Questions will be many more.
If it's a congenital condition?
Yeah.
Or genetic condition?
Is it erythroblast? No. Fetalis.
You have some idea, Chinmay? That is certainly you have some idea.
Fetalis. I'm unable to recall the name exactly. Hydrops. This is a hydroxide.
Anyway, condition already you answered. Name the characteristic sign of the condition.
Nikolsky sign.
Nikolsky sign.
Arthi, can you
Nikolsky.
describe how the Nikolsky sign? Somebody will ask in the exam that demonstrate how you examine for the Nikolsky sign.
Sir,
Very
if
good.
if we rub the skin, it is easily peeling off.
Absolutely. But how will you rub? You know that, definitely. If you ask a dermatologist, they should be able to demonstrate you. Or I think their videos are available. Just look at once, you will never forget it. That you know, the people say that you use this eraser or your finger without nail and use the glove, and then you just shear it, and just if you shear it, rub it, very rightly Arti said, then with the minimum even shearing, the skin is getting separated, layers goes away. Very classical. That is Nikolsky sign, and I think that is the characteristic of this staphylococcal scarlet skin syndrome. In which other condition the sign can be there? You can ask dermatologist.
Epidermolysis bullosa.
Epidermolysis bullosa, no.
Pemphigoid.
Yes, pemphigus vulgaris.
Pemphigoid. Yes.
That is, in short, they say autoimmune disorder. One of the autoimmune disorder which we can refer to pemphigus vulgaris. Infection point of view staphylococcal. And even one drug. And the drug which is responsible for erythema multiforme. They said that in erythema multiforme also, the Nikolsky sign will be there. But who was Nikolsky? Any idea? Was he a pediatrician? General knowledge question. He was a dermatologist. Please remember, and what is the toxin responsible for this? The toxin is very important for the pediatrician. Epidermolytic toxin, exotoxin, what we say, that's for the exfoliation. But very important question for the treating person, which antibiotic you are going to use it. Because ultimately we have to manage the patient. So here I will say choice of antibiotic is very important. Somebody is going to ask in the Viva or exam. I think you said staphylococcal. Then it should not be difficult. Please remember, sometimes somebody asks in the Viva or even in the short note, somebody may ask anti-staphylococcal agents. And I think every pediatrician should know. Starting from oral to injectable, to manage even simple OPD patient, like the suppose skin infection, impetigo, due to even bullous impetigo, or even due to something staphylococcal pneumonia, to even the staphylococcal osteomyelitis, to even the staphylococcal scarlet skin syndrome, even the staphylococcal toxic shock syndrome. You know, all these are the various conditions with staphylococcal, and in our pediatric practice, it is not uncommon. Therefore, every pediatrician should be very clear that what you are facing and very specific choice of the antibiotic should be there. So I think here, what should be the antibiotic of choice?
Amoxicillin. Ampicillins are amoxicillin and
Always another thing, look at the seriousness of the condition. When the seriousness is there, then you go for this very specific, I will say, antibiotics, which they
linazole.
Vancomycin.
Injectable vancomycin.
good answers are coming, multiple choice for the examiner. And now he has to choose out of all these. Good. Please remember, Simply just I will give some ideas. Skin infections in the OPD, where you are suspecting staphylococcal, go for the cephaloxime or even the cephaloxime. They are very good OPD, I would say anti-staphylococcal agent for the OPD conditions, commonly with the skin infections. Yes, amoxicillin is not that bad. It is anti-staph, but not good anti-staphylococcal. Mild infection you can give, nothing is wrong. Suppose abscess, even if you are drained, and you can go for amoxicillin. But if you want, you have done some surgery, suppose osteomyelitis or something, then go for the cefazolin. Injectable cefazolin is also very good anti-staphylococcal. And suppose pneumonia or something, and which you are suspecting MSS, methicillin susceptible, then amoxicillin or cloxacillin. But suppose staphylococcal patient is presented very badly, bad infections or shock even, then you have to, or suppose complications of pneumonia like necrotizing pneumonia, abscess formation, then you have to work, I will say, hit very hard. And MSSA then go for the combination of, I will say, suppose ceftriaxone and cloxacillin. Ceftriaxone, because we are not sure whether the streptococcal can also possible. So you can go for the cloxacillin. Or suppose MRSA, then go for the vancomycin. And suppose there is possibility of toxin liberation like pentavalent glucosylcerin, PVL, that is pentavalentine glucosylcerin, or even the super antigen. You must be knowing the super antigen also, toxic shock syndrome. Then you can go to block these toxins or agent, and for that clindamycin or even linezolid. So for MRSA vancomycin, vancomycin, the linezolid is not superior to vancomycin in MRSA. Please remember, MRSA is a very good answer to the MRSA. And if there is a chances of some complication like toxin or super antigen, you have to add the clindamycin, or very bad patient, bad even occasionally you can go for combination of vancomycin and linezolid. Not commonly, but occasionally, yes. So I think all these staphylococcal agents, you should know it. This is, in the exam also, one case, one X-ray, one something, it is just to start the dialogue, discussion. Ultimately, they want to know that how best manage the situation. So cloxacillin and clindamycin even, or vancomycin and clindamycin, because here the toxin is to be blocked. So clindamycin is very important answer. I'm sure that probably we have crossed time. We will go for a few and then we'll stop over here at some other time. There are big collections, so multiple times we can do. This was the 2-year-old child presented with the scabies. You can see very obvious scabies is there. And even this general lymph.
More of your this OSCE for another session also, sir.
Yeah. So I think now within short time we'll stop over here. Failure to thrive and taste for some infection was confirmed. What is the condition? Quite obvious. This patient was failure to thrive, some systemic infection. And this child has a very bad scabies, lymphadenopathy, and one investigation confirmed the diagnosis. So what is the condition? It's an immunological condition.
HIV.
HIV, good. HIV is known to present in this way. Second, which variant of human scabies is commonly associated with this disease, Shivangi? HIV?
Scabies.
Sorry?
Nodular scabies.
Some other name is there. I understand there's something there in your mind, but you are not able to recollect it properly. Rather than, what are the types of scabies? This is Norwegian. This is Norwegian scabies. And here, drug of choice is, ivermectin. 0.2 milligram per kg is a single dose. And name of the mite?
Sarcoidosis scabies.
Yeah, Sarcoidosis scabies. Absolutely, Sarcoidosis scabies, hominis. I think let us go this last one. This was 8 years old male child, difficulty in chewing and swallowing. There was some injury. Child was not vaccinated in the past at all. And this is,
Tetanus, sir, it is.
absolutely, absolutely. And what is the name of this condition? Name of
Rhesus
sorry,
sardonicus.
sorry, Rhesus sardonicus. Very classical. Mechanism of this sign, you know, which muscles are involved, buccal and facial. And what causes the sudden death in the child? You are fortunate that you don't see the tetanus. We have seen several patients of tetanus. Patient of improving the
Respiratory
amount,
failure.
Respiration.
not failure. Respiratory, yes, but not failure.
Spasm of the diaphragmatic muscle.
Not diaphragm will not cause the sudden death. Here, sudden death. Even sometimes many people must have faced that about to discharge the patient and suddenly die. Even that has been happened. And that causes laryngeal muscle spasm, causes asphyxia. One spasm causes the death even sometimes. That's very, very important. And you know, it's a vaccine preventable condition. So now it should not, fortunately, you don't get the patient. Which antibiotic, suppose by chance if you get the patient?
Penicillin group of
Penicillin or
Penicillin.
metronidazole.
Shivangi, in which other conditions you will go for the penicillin and nothing else?
Diphtheria.
Metronidazole.
Absolutely, absolutely. Diphtheria,
syphilis.
syphilis, very good. Even leptospirosis. Of course, now Septagon people recommend if you don't have the penicillin. But you know, still the penicillin has maintained, I would say, status in some of the conditions. Okay, I think now we have to stop over here. I hope that, yes, we have almost crossed the time limit.
Yes. Thank you so much, sir.
I hope that purpose is served.
Sir, it was going such a nicely, like a water flow in the river. So everyone enjoyed, including me.
I think first let me appreciate Nehal, all the students, those who participated. Really, they are extraordinary. I would say not just they responded very nicely, and but just this was my attempt to sensitize the students. Most of the examiners, every exam they will have some different pattern, different way of discussion. But you know, most of the they will be having the thoughts, ideas will be same. That having some condition, then they want to know that suppose if you come across, how will you think, how will you try to manage, how will you diagnose, how will you explain, or how will you talk to the parents. And I will say prevention, vaccination, you know, pediatrics is many preventive branch. And gradually now probably almost only preventive. It is developing like that. So this was the idea that, and I'm sure that if you are sensitized, these are just some examples. Probably it should be useful to you in the exams. That was the idea. And I think with that idea we have tried. I hope that you must have taken the proper perspective and it should be useful to you. I should appreciate and thank Dr. Nehal, Dr. Yogesh Bhai, Madam Arti from BJMC Pune, and Dr. Vaishali, and so many even friends, colleagues to give this opportunity. And probably this is something new idea and it should be useful to them. Thank you very much. Over to you, Dr. Nehal.
Thank you so much, sir. I must thank all the students. They responded just within 2 days, that when we told that we are going for the OSCE, and I asked their teachers, they gave me the names within half an hour. And we had a mixed bag of students this time, second year, third year, past students. So it was going to be a very nice discussion as we thought. And really, sir, your questions from the basics to going to the pictures, and everybody enjoyed. We would like to have another session of this kind again.
Thank you very much.
And thank you all the students, Chinmay, Chandraprakash, Aarti, Durija, and Shivangi. So Dhaval, Sagarika, they all joined and they were giving some inputs in writing, but all the 5 students were interacting very nicely. So the flow was very nice. Anand Keshwan sir has just joined. Sir, welcome, sir.
Thank you very much, Dr. Anand.
So, sir, we have a two added learner also, Dr. Anand Keswan and our permanent Dr. Srinivasan, sir.
Srinivasan sir is, I will say, big force for us. He's
Yes,
a force.
sir, mostly from the joining from the abroad.
Yeah, he's at USA with his, I will say, daughter, and still finding the time and enjoying with the family. And but he hardly misses this opportunity.
Yes, sir. His role today was giving hints to the
Students,
panelists.
yeah.
So
I think even I request the student that whatever the questions you are in your mind, suppose if you gather the information from your friend that some examiner was asking this question or something, I think you can pool all the questions. Even you can send to me or some other teachers, and probably you can have the good connection. So probably at the time of exam, even probably you should not find the difficulty. Thank you very much again, Dr. Vijay.
thank you so much, sir.
So, thank you,
Uh,
sir. Thank you.
certificates. I will deliver those certificates personally to everyone just to save the time.
Yeah, we have to join another meeting, madam. Just 15 minutes.
Yes,
For... So, I am logging on the other meeting.
thank you so much, Clarinet, for providing this platform. Thank you.
Thank you very much. Good night.
Thank you, Baldev sir. Thank you, Nehal madam.
Good night.
Thank you, Yogesh sir.
Thank you, everyone. Credit is really glad to have all these brilliant people together in this session today. And thank you so much for extending us the opportunity to host the session. I hope you all had a seamless experience. With your due permission, I'm closing the session today and looking forward to hosting you again. Bye and good night to all.
Good night.
Thank you. Thank you.
Good night.
Thank you, sir. Thank you, Baldev sir. Thank you, Nehal
Good
madam.
night. Thank you.
Thank you, Yogesh sir.
Thank you. Thank you. Welcome. બધા આવી જાઓ. સર નેક્સ્ટ સેશન પછી રાખીએ.
Okay, sir.